Dysphagia is a condition recognized by the World Health Organization that includes several oropharyngeal dysfunctions leading to the difficulty or the inability to move the alimentary bolus from the mouth to the esophagus, and can include oropharyngeal aspirations. The process to recognize patients with oropharyngeal dysphagia has two main steps. The first one, the screening process, means that we should use simple methods such as the E10, or for instance, now we have several algorithms of artificial intelligence to select the patients that are at risk for oropharyngeal dysphagia. So the end point of the screening process is the identification of patients that are at risk of the condition. Then it starts a second process that is called diagnosis, and that can include clinical diagnostic methods such as the volume viscosity swallow test that has a high accuracy to identify the patient with oropharyngeal dysphagia and those with impaired safety or efficacy of swallowing. We have a very recent systematic reviews that prove that the psychometric properties of this method are very good. And then another family of methods that are the instrumental methods that can provide physiological information on the disturbances leading to oropharyngeal dysphagia. And among these methods, we can cite video fluoroscopy, FEES, and pharyngoesophageal manometry. This is a very relevant question, and the first thing that we should do is to recognize that for many patients, oropharyngeal dysphagia is still a neglected condition, meaning that many patients with dysphagia don't have a proper diagnosis and will not receive a treatment for this condition. I can provide you some big numbers telling that nowadays the prevalence, the number of patients with oropharyngeal dysphagia living in the States is 60 million people. We have 30 million European citizens and 8 million Japanese citizens suffering with oropharyngeal dysphagia. And in Europe and in the States, the condition is only recognized in 20 or 25% of those patients. So high prevalence similar to other diseases such as diabetes mellitus, and in contrast, a very reduced proportion of patients properly diagnosed and receiving an adequate treatment. First, muscle function is involved in swallowing function and also respiratory function, and both will contribute to impair safety and efficacy of swallow in our patients. First, reduced muscle function can impair and reduce hyolaryngeal excursion, contributing to delay laryngeal vestibule closure and contributing to impaired mechanism of airway protection. And second, reduced muscle function can contribute to reduced tongue thirst and leading to oropharyngeal residue. And this causes also post-deglutitive aspiration. Finally, reduced muscular strength can impair respiratory function and the coordination between respiratory and swallowing that is imperative to guarantee a safe swallow and swallowing during expiration. That's a very good question, and the answer is yes. There is a double link between dysphagia, malnutrition, and sarcopenia. In one hand, we know that dysphagia will cause malnutrition and sarcopenia in our patients. And we have many results coming from our studies at the Hospital de Mataró showing that oropharyngeal dysphagia is an independent factor for sarcopenia and malnutrition in elderly patients admitted at our institution. On the other hand, we also know that once stated, malnutrition and sarcopenia will contribute to oropharyngeal dysphagia, further aggravating a vicious circle that will impair swallowing function. Well, this is a very appropriate, that's a very interesting question. We have seen during the webinar the concept of rehabilitation nutrition by Professor Wakabayashi. And we have also seen the role of proteins in those patients by Professor Litchford. The idea is that we should integrate all these therapeutic messages in a protocol linking diagnosis and treatment. And therefore, we urgently need validated integrated protocols to screen, assess, diagnose, treat, and monitor all these conditions to improve the outcome of older patients with oropharyngeal dysphagia, sarcopenia, and malnutrition.